1938, the isotope came into clinical medicine in the form of radioiodine, which was delivered by Professor Seeberg, who got a Nobel Prize in 1951. So then on, in fact, the entire nuclear medicine start moving, and that was not the time when imaging was there, but the isotope was invented and it was used at the Michigan University without imaging for treating thyroid cancer and thyrotoxic patients. The first thyroid scan was performed in 1950 by Professor Benedict Casson, who was the inventor of the thyroid scanner. And what you see here is the first thyroid scan where two lobes of the thyroids are nicely visualized. So that was the birth of nuclear medicine. Coming to the field itself, in the thyroid area, when we look at the isotopes, they are of two types: metabolic isotopes and isotopes which give us the morphology of the thyroid gland. The metabolic isotope is the radioiodine. Why do we call it a metabolic isotope? Because we all know from the physiology of the thyroid is to take up the iodine molecule and organify it and produce T3 and T4 hormones, which are critical for functioning of every organ of the human body. So a isotope of the iodine molecule is the radioiodine 131 is used, and hence we call it as metabolic scan. The picture that I get from the scan is telling us nothing but iodine distribution in the thyroid gland, the iodine trapping by the thyrocyte, the organification of that into hormone, and a hormonogenesis. Hence we call metabolic scan. But in day-to-day practice, we do not use this isotope routinely. We use a morphological scanning isotope called technetium. Why is that? Because the energy radiation of radioiodine much higher than the technetium, and we do not intend to give unnecessary radiation to the thyroid gland just to achieve a diagnosis. So we use technetium isotope for imaging of the thyroid scan. Is it all right? Am I audible?
Yes.
इसका इमेज कैसे चला गया?
In thyroid imaging, the equipments that we use are called as the gamma cameras, which take the image, and what you see here is a new type of thyroid scan image scanner which can be put in a corner of a clinic. In the United States, these are used in a clinic. And this is a gamma camera which produces the image. And we also have what is called as thyroid uptake probe. Now this probe detects the amount of radioactive iodine picked up by the thyroid gland, and this uptake information is critical in enzyme deficiency goiter and in calculating radioiodine dose to be given to the thyroid gland for treatment of either thyrotoxicosis or thyroid cancer. So this is a fundamental of the technology that we use to obtain the image. This is the scan that you are seeing here, the first the technetium scan of the thyroid gland. And what you see here is the two lobes of the thyroid nicely demonstrated. And what we see in a thyroid scan when I report and it comes back to you is the distribution pattern. Is it uniform? How are the lobes? Are the margins smooth? And normally the left lobe is slightly smaller than the right lobe. In about 20% of the patients, we see the pyramidal lobe in the midline or towards the left side. And the salivary glands show up the uptake both the parotid and the submandibular, and this is the oral cavity isotope which comes through the saliva into the oral cavity. So on a thyroid scan, you see the thyroid gland and the salivary gland and oral activity. Normally, the thyroid gland uptake is far, far higher than the salivary glands and in the oral cavity. So this is a normal thyroid scan. How does the radioiodine go into the thyrocyte? Via sodium iodide symporter, which is present at the membrane of the thyrocyte, which pushes the iodine into the thyroid gland through an electrochemical gradient, and that is a sodium-potassium ATPase pump. So, for a thyrocyte to accumulate iodine, sodium iodide symporter function is very critical. When the sodium iodide symporter is not there, thyroid site cannot accumulate iodine. This is a fundamental point you must remember, because later on in the thyroid cancer, this concept comes back again. So as of today, indications in thyroidology are in the assessment of a solitary thyroid nodule, which you clinically palpate, or in thyrotoxicosis, where you want to differentiate Graves from thyroiditis, and in ectopic thyroids, in agenesis of the thyroid, and finally in the thyroid cancer follow-up patient. These are the main indications today for a thyroid scan in clinical practice. Now let us take the solitary thyroid nodule. As you see here, this nodule, which is palpable clinically in the OPD, when you palpate this nodule, what are the questions that come to your mind? Is this nodule a functioning thyroid nodule or a non-functioning thyroid nodule? If it is non-functioning, is it malignant or benign? If it is a functioning nodule, is it an autonomous nodule or a non-autonomous nodule? If it is non-autonomous nodule, does it respond to thyroxine suppression therapy? These are all the questions that come to your mind on an examination of a solitary thyroid nodule. Unlike the sonography, which forms the first investigative modality in a solitary thyroid nodule, the thyroid scan gives answers to all these questions, whereas the ultrasound will give only one important information, that it is echogenic or it is non-echogenic. Now, after that, you follow it up with an FNAC. Whereas on a thyroid scan, if it is a functioning nodule, you don't need to do an FNAC on that nodule. If it is a non-functioning nodule, it needs an FNAC evaluation like what you get in an ultrasound, a echogenic nodule. If the functioning nodule is autonomous, why do I need that information? An autonomous nodule functioning is not treated with thyroxine. It will become thyrotoxic. So hence, this information is critical right at the onset of the clinical evaluation. If it is a non-autonomous nodule, it is going to respond to thyroxine therapy, so you do give thyroxine. So one isotope scan helps in answering 5 questions which a clinician gets in the mind. Professor Bear Walters from Michigan University wrote a fabulous book and said that though all over the world, if the ultrasound continues to be the modality, he said he looked at it and said, no, it does not answer all these 5 questions. Then why is ultrasound the first modality? Because isotope scanning is not available everywhere across the country, whereas ultrasound is available at every clinic. So ultrasound becomes an easier modality to investigate rather than isotope scan, even though it has a high potential to answer all your questions. So in the workup of a solitary thyroid nodule, from a clinical standpoint of view, ultrasound followed by FNAC is the current approach. Please remember this. However, when an ultrasound shows an echogenic nodule and the FNAC shows follicular cells, then you do not know whether it is a functioning nodule follicular cells or it is a follicular cells from a non-functioning nodule. Because follicular cells from a non-functioning nodule would need definitely surgery. A follicular cells from a functioning nodule does not need surgery. So, depending upon the characteristics and the clinical scenario, you need to combine sonography with the isotope scans. Now, here is the same patient who had a nodule, and what are the types of scans you are getting? You may get a cold nodule, as you see here, and this nodule has to be surgically tackled. 25 to 30% of these nodules carry malignancy. You may have a nodule, the nodule may look iso-intense to the rest of the thyroid, which is called as a warm nodule, or the nodule might show uptake higher and the rest of the thyroid uptake is not visualized. Now, this is called an autonomous toxic nodule here. And this is called as a functioning nodule in the right lobe of the thyroid, whereas this is called as a cold nodule harboring malignancy. That is how you interpret a thyroid scan. In a thyrotoxic, supposing that patient who had a clinical nodule was thyrotoxic, and you want to differentiate whether it is a primary or you want to think of a radioiodine treatment, then the thyroid scan will come into picture. It will also differentiate primary from secondary thyrotoxicosis. Look at this scan. High uptake in the thyroid gland in a clinical scenario of TSH suppressed and raised to T3, T4 is grave the thyrotoxicosis. Whereas no uptake in the same clinical setting is acute, subacute thyroiditis. So that is how scan helps in the clinical diagnosis. Now, we also on the scan get developmental anomalies of the thyroid. When you get clinically, you find some types of swellings at different areas of the human body. Now, let us see here, you have examined, you got a swelling in the posterior 1/3 of the tongue, an iodine scan is done, uptake in that area tells you it's a lingual thyroid, and there is no normal thyroid. This information is very critical because if the normal thyroid is absent, you may have to take this lingual thyroid and implant, and so that there is a functioning thyroid in the human body. A patient may have a nodule like this, raising all same questions, and when you see on the iodine scan that is showing high uptake and there is no thyroid gland, this is a thyroglossal cyst which is functioning. Not very common, but it is a functioning thyroglossal cyst. You may have a dual ectopia, a lingual thyroid and a thyroglossal cyst with no thyroid gland. You will have an agenesis. The nodule may be clinically palpable, but when you do the scan, the left lobe is absent and there's an agenetic left lobe. You may have a triple developmental anomalies like a lingual, thyroglossal cyst, and also an ectopic left neck thyroid swelling. Now, these are all areas where the ultrasound and other modalities will not be specific, so iodine scan is critical in the diagnosis. Now, today I will be talking to you about the thyroid cancer as the main topic and the isotope role. Thyroid cancer, 1.3% of all cancers, prevalence 0.4%, 4% at autopsy. Well-differentiated cancer forms the main core of this group, 75%, papillary, follicular, and mixed. Poorly differentiated forms about 20%, Hürthle cell and anaplastic carcinomas, and medullary thyroid cancer, 5%. So in a pathologically speaking, papillary, follicular, Hürthle, medullary, these are what I'm going to cover today in this small talk. So for thyroid cancer, the treatment approach is surgery, radioiodine, and thyroid hormone. Rarely should a patient die of well-differentiated thyroid cancer if treated in time, adequately, and very scientifically. That's an important point to remember. Radioiodine treatment in thyroid cancer, what is the concept? Radioiodine emits gamma and beta rays. The beta rays have therapeutic effect and are used in treatment of thyrotoxicosis and thyroid cancer. Thyroid follicle traps radioiodine, and during its stay in the follicle, the radioiodine delivers radiation dose, resulting in either total or partial ablation of the cancer cells. Papillary and follicular thyroid cancer cells and their metastatic lesions retain the phenotype property of trapping radioiodine, and hence they can be detected on radioiodine scan after total thyroidectomy. They do not use this for hormonogenesis. That is, thyroid hormone is not produced by a metastatic thyroid cancer which accumulates radioiodine. The beta rays of I-131 are used to treat the metastatic lesion. This is referred to as radioiodine ablative therapy and is the first disease-specific therapy in oncology since the last 70 years. Radioiodine therapy in thyroid cancer, the role starts after total thyroidectomy. Before total thyroidectomy, it does not have any significant role. This fundamental point you must all remember. Now the question comes, why total thyroidectomy? If you do a near total thyroidectomy and have a radioiodine as a treatment option, there is a higher survival rate. The thyroid cancer is known to be multicentric, intraglandular lymphatic spread, and post-operative recurrences. They all can be tackled if you do a near total thyroidectomy. In a post-operative follow-up setting, radioiodine cannot be used if you do not perform total thyroidectomy, because the thyroid tissue which is in the neck will pick up all the radioiodine and the metastatic cells will not pick up, and this is called competitive inhibition between the thyroid tissue and the metastatic tissue. Hence, the main organ has to be removed for the metastatic cells to pick up. So remove the thyroid cancer that is not concentrate I-131. Success rate of iodine-131 ablation of remnant thyroid increases significantly if you do a near total thyroidectomy. In the post-surgical evaluation of patients for after surgery, the main reason is to find out how much of the neck tissue has been left by the surgeon, and secondly, to pick up distant metastases which occur at different percentages in different areas of the human body. So how do you prepare a patient for radioiodine scan? You need to first avoid the competitive inhibitor, that is the iodine. So any medication that contains iodine, if a patient is taking, that will inhibit the uptake of radioiodine. So one has to avoid all those. As a surgeon, you must know one thing, that when you are trying to do any procedure on these patients, you should not use betadine or iodine containing cleaners, because they have high iodine content and the radioiodine scan gets affected. Iodine containing food and medication like fish, iodinated contrast, omiodarone, all these affect the radioiodine scan. A low iodine diet can significantly increase the uptake of radioiodine and sensitivity of scintigraphy. So low iodine diet for 3 to 10 days prior to radioiodine scan is mandatory. In fact, one other thing which I would like to tell you is fish is the one which gives a major problem to us in our whole body iodine scan scenario. So what are the prerequisites? Total thyroidectomy is mandatory. Confirmed histology of differentiated thyroid cancer. TSH level should be around 40 microunits when you are trying to give a radioiodine scan dose. This normally occurs 3 to 4 weeks after the total thyroidectomy. Patient should be off thyroxine for at least 3 to 4 weeks before you do a radioiodine scan during follow-up. Pregnancy should be ruled out. Lactating mothers should not be subjected to radioiodine scan. There is significant uptake of radioiodine in lactating breast which gives unwanted radiation to breast epithelium. So it is mandatory we do not take them. If there is a necessity to perform, then the breast milk I always advise 6 months to 8 months, wait and then perform. Thyroglobulin and anti-thyroglobulin antibody test should be done along with the TSH when you are about to perform a radioiodine scan. The level of thyroglobulin helps us in decision making on the iodine scan findings. The anti-thyroglobulin antibody is extremely critical because it suppresses the thyroglobulin and gives you a false sense that as though there is no disease. So raised anti-thyroglobulin antibody, normal thyroglobulin level does suggest that there is a disease somewhere in the body. So all these three is a combination of workup: TSH, TG, and anti-thyroglobulin antibody. In some of the patients who do not tolerate remaining hypothyroid, there is a new trend now. It is called recombinant TSH technique for whole body iodine scan. Now this has come up in about I started it in 2008, first time in India, and now we are doing it at many multiple centers. The recombinant TSH is licensed for commercial use. It is used to induce a rise in endogenous TSH without the need to stop the thyroxine treatment. And therefore, it helps in imaging and increases the uptake of the therapeutic and diagnostic dose of radioactive iodine. It produces comparable diagnostic information to withdrawal of a thyroxine state. So there is now ample data to tell us that if you take off thyroxine for 4 weeks and do the scan, or while on thyroxine, if you do the scan under RTSH injection, the yield is same. So what we do is we try and see the clinical scenario and accordingly use this particular technique. You give 2 injections. On day 1, the RTSH is given 1 injection, and then you give the TSH actually after 1 injection rises to 80. And then when you give the second injection, it rises to 145. So on an average, this is the TSH you get when you inject this, and the thyroglobulin along with the TSH also rises. Now this raised TSH remains at that level for about a week. After that, it comes down. So whatever we would like to do, we need to do during this particular 1 week when the TSH is high. So pre-TSH, if the TG is 4,300, post-TSH injection, it rises to 7,400. What does it mean? TSH-stimulated thyroglobulin has come into the circulation. That is how the tumor behaves to the TSH. Now, this injection is extremely expensive. 2 injections cost 80,000 rupees. And that is why it is something which is difficult in an Indian scenario. But the American Thyroid Association today makes a solid recommendation that in all the patients, it is only RTSH stimulated whole body scans or RTSH stimulated thyroglobulin. I have now more than about 150 patients in this scenario, but slow and steadily we are if the cost factor comes down, I think this should be the best way of investigating rather than making the patients hypothyroid. Now, this is a whole body scan, which you can see here. The remnant thyroid tissue is seen here, and there are mediastinal nodal metastasis, and that's the stomach uptake here, and that's the bowel. Now, we also do, apart from this, tomographic images with the fused CT images, and we try to find out exact location of these sites of residual thyroid tissue. So after the scan is done, then a decision regarding therapy is taken. But it is also critical now that after the total thyroidectomy is done, and when we want to perform a radioiodine scan, we need to risk stratify the patients, low risk and high risk, depending upon various parameters like the tumor size, its infiltration, lymph node status. So all these help us in taking a decision about radioiodine treatment. In low risk patients, giving a radioiodine treatment is not very strongly recommended. If the thyroglobulin level is less than 5 nanogram, and even if you have a small residual thyroid tissue in the neck and it is in the low risk category, one does not proceed to radioiodine treatment. So what am I trying to say here is, it is imperative that we do a risk stratification, post-surgical histopathological risk stratification before going ahead with radioiodine treatment. In fact, in the American setting and the European setting, they feel that if the TSH stimulated thyroglobulin is less than 5 nanograms and you don't even need to do a whole body iodine scan. As of now, in India, I do follow in some young patients with extremely low risk factor with that thyroglobulin level. Why I am saying this is, the estimation of thyroglobulin at the time of whole body scan is critical in decision making about this particular treatment. Now, thyroglobulin is a very important component of the entire scenario because it's produced by the thyroid gland. It is elevated in many thyroid diseases, but when a thyroid cancer is surgically removed, the whole thyroid gland is usually also removed. So only after the complete removal of the thyroid gland, the thyroglobulin level becomes very, very decisive in taking treatment decision. If there is a thyroid tissue left in the neck, then the sensitivity of thyroglobulin goes down in the decision-making process. So any elevation of thyroglobulin above about 10 nanogram suggests that cancer has returned, or it tells us there is a metastatic disease. So it is used to evaluate not only the status of the disease recurrence and also in the treatment effectiveness during follow-up. So TG is not a specific marker of thyroid CA, but thyroglobulin plasma concentration correlate well with the tumor mass and the metastasis. In athyrotic state, plasma concentration should be less than 2 nanogram per ml. If it is so, you are very, very sure there is hardly any clinically significant disease. Any post-treatment elevation of thyroglobulin concentration indicates either remnant thyroid tissue requiring further ablative treatment or indicative of metastasis. Today, this word here is called as stimulated thyroglobulin. What does it mean? TSH is high, 40. So under high TSH, thyroglobulin production is stimulated. So stimulated thyroglobulin, if it is less than 2 nanogram per ml, you have no issue about that particular patient having any significant clinical disease. Coming to radioiodine therapy itself, it is of two types. One is remnant ablation and second is treatment of the metastatic disease. how do we give this radioactive iodine? In my older days, 30 years ago, it was all in the liquid form where patient would take orally. But today the BARC gives us the radioiodine in a capsule form. So the patient is given the radioactive iodine therapeutic dose in a capsule form. And the therapy is given in an isolation room. As you see here, this is our isolation room at the Raheja Hospital. And and in that isolation room, the treatment is given and the patient stays in the isolation room for 2 to 4 days, depending upon the dose that we have administered to him. If we have administered less than around 50 millicurie, he stays about 1 or 2 days. If it is more than 100 millicurie, he stays for 2 to 3 days. This is done because patient's saliva, the sweat, the urine, all of them contain radioiodine, which is not taken up by the metastatic tissue. Now, this would be in and around his bed, on the floor, everywhere. And this is a highly contaminant isotope. And if it sticks to anybody's hand or dress, it will keep on giving constant radiation. Number two, during the first 2 days, the entire radioiodine that is given to the patient is in the body, and he will be emanating radiation which will reach a far off distance, more than 3 meters and 4 meters, producing considerable radiation to the surrounding people. So, as per the atomic energy rule, by 2 days or 3 days, the whole body radiation dose come down to such a low level that at 6 meter distance, there's hardly any radiation. This is at that time we'll release him and he does not become a radiation hazard to either his family members or to the surrounding people. Overall, the radioiodine treatment gives a survival of 75% at 20 years. Now, I'll just show a few examples. This is a patient of ours of post-total thyroidectomy. You see 3 areas of tissue in the neck, and that's the bowel uptake here, and that's the bladder here. And this patient was treated with 75 millicurie of radioiodine, and in the follow-up scan, there's a total ablation of the disease. So this is an excellent response in one shot. So majority of the remnant thyroid tissues get ablated in one dose itself. This is another patient where you see the tissue is quite small. It is showing an avid uptake. That's the stomach uptake here. Radioiodine accumulates in the stomach also, but then clears off. And in the follow-up scan, he continued to have some amount of residual tissue, and he needed a second dose, and then he completely got ablated. This is a patient where, interesting, what we call this sort of a therapy, we call it as adjuvant radioactive therapy. That is, the tissue was small, but the thyroglobulin was very high, 543 nanogram per ml, suggesting that there is a metastatic disease in this particular patient. So here, instead of a small dose which we give for these tissues, we go ahead and give a high dose, more than 100 millicurie, because we are worried about the metastatic disease. But in this patient, the metastatic tissue did not pick up because it was the anti-thyroglobulin antibody that was high, and the thyroglobulin was just 2 nanogram. Now, this is called as a patient. About this I'll discuss later. The metastasis has lost the capacity to pick up radioiodine. What are the metastatic sites in thyroid cancer? Bones, brain, lungs, and visceral metastasis. Now, this is one of our patients. You see here that this patient actually had no major symptoms at all. He had actually come for an ablation of the residual tissue. On the scan, what we found was bilateral lungs showing diffuse radioiodine concentration. And look at the chest X-ray here. There is nothing in this chest X-ray. And even in the CT scan, HRCT, there is no disease. Now, this is called occult pulmonary metastasis. When somewhere in 1984 in a UICC Congress, when I was at Tata Hospital, I made an analysis of 1,000 patients of thyroid cancer operated at Tata's, and our incidence of occult pulmonary metastasis was 6.8%. And the MD Anderson Cancer Center had reported 7.5%. Now, why is this important? If we had not done total thyroidectomy, this would not have been picked up because all the radioiodine would have gone to the thyroid tissue. So that is the relevance of doing a total thyroidectomy. And number two, this is an asymptomatic patient. So why does one worry? But when you treat a patient of occult pulmonary metastasis, that is negative on the chest X-ray and on the CT, but on iodine scan alone positive, when you treat such a patient with radioiodine, you ablate the disease completely in 70% of the patients, compared to those patients who have already disease on the X-ray or on the CT, where the nodules are already seen, and when you treat those patients, your ablation rate is just around 25 to 30%. So you have a 40% jump in the ablation rate by picking up the occult disease in a thyroid cancer. Look at this patient here. He has bilateral pulmonary metastasis. He was also treated, but there are still some focal areas of uptake present in the lung. And that happens because if you see on the CT, where there were nodules seen, there the ablation had not completely taken out. Where there was no nodule or no parenchymal disease, all that area got ablated. However, in the second dose later, this patient did ablate. So this is a beautiful scan to show the relevance of total thyroidectomy, number one, the relevance of picking up occult disease in oncology as early as possible so that the therapeutic efficacy is enhanced. Now, this is a patient which I just did about a few months ago. This is where you have a post-total thyroidectomy, follicular CA thyroid, with pelvic bone mets and a large soft tissue mass with the pelvis. There is a remnant tissue here, and the soft tissue mass in the pelvic bone is picking a high concentration. But what happened was that if you see, if I could carefully see here, there are 2 or 3 dots in the chest area which we see. These were lung mets which were seen on the CT, but the uptake was less because most of the radioiodine took up by the large soft tissue mass. So in such a scenario, if we continue to treat with radioiodine, it doesn't make sense because we will not achieve any ablative therapy for a lung metastasis. So I asked this patient, you can see this mass here, a very large soft tissue mass on the MRI in the right pelvic region. So this patient underwent complete excision of the soft tissue mass, and following that, he has now come to us for whole body radioiodine scan, which was done last week. And what we are seeing here, his thyroglobulin level is still high. At this level, it was 1,800. Now it's around 330. The remnant tissue did not get ablated because the radioiodine accumulation there was much less because everything went to the soft tissue mets. And now the remnant tissue is showing good uptake, and the lung lesions are still not showing any uptake on the diagnostic scan. This coming Monday, this patient is going for a 200 millicurie radioiodine therapy in the hope that when given a high dose, the pulmonary metastasis will pick up. Such a thing that is negative on large dose scan, whole body scan, but positive on a post-treatment scan occurs in 10% of the patients. What does it tell us? That this pulmonary metastasis, avidity to radioiodine is less, much less, and probably will not respond in the years to come, and we need some other modality for the lung metastasis. It's a beautiful scan to show how you must get back the surgery wherever it is needed and not hook on only to radioiodine in the overall management of a thyroid cancer. I have some 8 or 9 patients like this where getting a surgery really helped the patients in prolonging their survival. Now, brain metastasis. This is one area which we are very worried. If you see this metastasis here has a concentration of radioiodine. Along with it, there are 2 other areas of metastasis. Radioiodine is not a good treatment for brain metastasis because when we give radioiodine, once it accumulates in the brain metastasis, we will not know, we cannot have any control on the effects that it produces. It may produce severe edema, severe vascular abnormalities. So in a brain metastatic setting, it is still believed that it is better to go for external radiation therapy where you have a control on the radiation effect. You can stop midway if patient develops complication. But in radioiodine, you have no such option. Once given, you have to manage the complications which come. So normally, I do not. Now, what is the impact of the radioiodine treatment in thyroid cancer? If you look at these 3 graphs, when I give only thyroid as a suppressive therapy, faults start coming. At a very therapy and eliminate the entire tissue, the recurrence rate is very slow and much less compared to treated only with thyroxine. And when you do not give any treatment, the recurrences are very high. This scenario is very rare now. So T4 thyroxine versus radioiodine as a treatment, ablation therapy has a definitive impact on reducing the recurrences. This is another interesting cancer death rates after thyroid remnant ablation. If you see those who did not have ablation, the death rate keeps on rising as the years pass, much earlier compared to those who had a remnant ablation. Whereas those who did not have any therapy, the death rate is rapid. So the remnant ablation definitely seems to be impacting on the overall survival and the cumulative death rate in thyroid cancer. This is one of the recent studies that has come up where you see overall survival and you can definitely see that where radioiodine is given, there is a phenomenal impact on the overall survival as well as thyroid cancer specific survival in the age group of less than 55 and those above 57. So scenario. So what is the protocol? It's a differentiated, that is papillary, follicular, and few of the Hurther cell carcinomas. Total thyroidectomy followed by I-131 ablation and post-therapy whole body scan. After that, you give a gap of, I normally give 9 to 12 months gap, then do either a withdrawal TSH and thyroglobulin assessment and neck ultrasound, or if the patient is affording, you can use RTSH, thyroglobulin and neck ultrasound, and if they are normal, you just hang on with the thyroxine. If the RTSH shows thyroglobulin more than 2 nanogram per ml, that is called stimulated thyroglobulin, and no abnormalities at neck ultrasound, then just observe this patient, yearly evaluation with TSH, stimulated thyroglobulin, anti-TG antibody, and neck ultrasound. If the RTSH shows thyroglobulin less than 2 nanograms or abnormalities at neck ultrasound, imaging workup, whole body scan, PET CT, surgery, treatment, they all have to be very carefully evaluated. And then my own philosophy is I do not interfere if the thyroglobulin is around 5 nanogram, and if it is above 5 can. Now at this juncture, I would like to make a statement that whole body FDG PET CT does not have a major role in the usual management of thyroid cancer. It only comes into play when your thyroglobulin level is very high and your iodine scan is not showing consistent metastatic disease or shows only one disease. In that scenario, you do a whole body FDG PET CT to find out where exactly is the other disease factors which are producing high thyroglobulin. There is an entity called tennis syndrome in thyroid cancer. Thyroglobulin elevated, negative iodine scan. That is the long form, tennis syndrome. Now, this is a very critical area where the entire radioiodine treatment gets completely eliminated from the algorithm in that patient because he is not concentrating radioiodine. What is the main reason for this? Loss of function mutation in the follicular thyroid cancer. Sodium iodide symporter is not optimally working or has got transformed. TG presence is there, but radioiodine is not going. Radioiodine is not going because sodium iodide symporter is not active. So that is the change that has occurred in this thyroid cancer cell. We call these cells as dedifferentiated thyroid cancer cells. This does occur due to various factors. In fact, one of the factors for this is repeated radioiodine treatment. When you give repeated radiation treatment to a cancer cell, there's bound to be a change in the structural integrity of the cancer cell. So one has to be very cautious about this syndrome setting in. So space the radioiodine treatment in a very careful, scientific manner only when needed in terms of patient's management. So when anti-thyroglobulin antibody level should always be tested when you want to say that thyroglobulin is low because of the antibody. Presence of anti-thyroglobulin antibody is same as high thyroglobulin level. Suggest patient, he must have that
This
option
meeting is being
as the first
recorded.
option. You can see lot of surgery is feasible. I always feel that must be the top priority. There is also a suggestion of some mediastinal activity in the hilar lymph nodes and in the pretracheal. Now, these need biopsy confirmations in some settings, but it is difficult to biopsy these areas. So one of the recommendations that are made here is that in such a patient, if surgery is done and the neck nodes are taken off, and then you go ahead and give a high dose radioiodine therapy, 200 millicurie, in the hope that when you give a high radioiodine dose, these metastatic nodes here may pick up. This is a one group of school of thought which is questioned by the other group, but I do this in a very selective patients and I have succeeded. But in those patients, the response rate will not be very high because they were not radioiodine avid to begin with. So even though I gave high dose, they did pick up, but they do not get enough radiation ablative therapeutic effect, and hence total ablation may not occur. So these are the patients where we need some other approach of therapy. But nonetheless, if the patient is asymptomatic in this scenario, and you have got rid of these nodes by surgery, and in fact, I got rid of this, and the 180 nanogram came down to 60 nanogram, suggesting that there is still disease, probably the mediastinal, but patient is totally asymptomatic. Now that patients can be kept under observation with every 6 months thyroglobulin levels. It is only when patient starts becoming symptomatic, number one, or there is a disease progression elsewhere. Apart from these sites, we will have to bring the newer approaches of treatment, which is currently what is called as TKI treatment. Tyrosine kinase inhibitors, lenvatinib is become the mainstay in tennis syndrome, and it has done wonders. I have had some good cases where thyroglobulin levels as high as 20,000 came down to 2,000 after 4 months of lenvatinib therapy. So lenvatinib today has become an important approach in tennis syndrome. As you see here, that there are metastases in the lung which are picking up radioiodine. But if you look at the PET scan, amount of metastatic disease that is present here, all of them are not showing radioiodine. So this patient progressed significantly, and this patient is a classic case for lenvatinib therapy. Now this lenvatinib therapy has come in the last 5 years. Data has accumulated already, and what it is showing is there is significant enhancement in both progression-free survival and overall survival. And as you see in this graph, the lenvatinib group shows an excellent progression-free survival improvement compared to those who are not treated with lenvatinib in a tennis syndrome concept. So I think these are the areas, the youngsters who are hearing us, this is in the future, you will all be dealing with this sort of group of patients. As in the last 2 years, I have seen more of tennis syndrome than what I saw in my earlier 20 years. Probably the assays were not good, or our technology was not as much as good as it is today. So please remember, lenvatinib is a new treatment approach in thyroid cancer. So what are some of the future trends in nuclear thyroidology? Iodine 124 PET scan is going to come shortly in India also. The isotope produced from Calcutta reactor will come all over the country, because this has got a long half-life, and I can take images for a long time of the whole body, and I can do what you call as quantitative imaging of metastasis of a thyroid cancer. Then I can do lesion-based dosimetry for radiation purpose. Therapeutic effects maximize reducing collateral effects. That is, the making a pinpoint radiation impact on the metastatic cell. Tumor stunning, which is an important concept today. It is difficult to explain here, but that will be avoided. Combination of PET and FDG PET improves restaging of thyroid cancer. Radiation dose, which we are giving today, is not well scientifically made out dose rates. We make an empirical way of treating radioiodine. But with the iodine 124 PET scan coming, we will be doing an extremely rational way of giving radioiodine, which will result in excellent metastatic response. Already data has accumulated on 157 patients in the European group. And probably I feel that with this isotope, we also start rationalizing thyroid cancer treatment. Not only that, in the tennis syndrome group, this is going to make a major impact. You just see this patient. Here is a patient, 69-year male, follicular thyroid cancer, multiple radioiodine treatment, disease progression, lymph node and bone, sorafenib and lenvatinib with no response. He had a BRAF mutation, and that was the main reason for this particular scenario. And when I-124 PET scan was done, only few areas of uptakes were seen. But the metastasis, other areas seen on the CT were not getting radioiodine. So what was done was, this patient was given 4 weeks of trametinib therapy. And after trametinib therapy, when you do 124 PET scan, look at the radioiodine uptake in multiple metastatic sites. So trametinib makes the dedifferentiated cell back into differentiated cell and allows the sodium iodide importer to become active and concentrate radioiodine again. A fabulous science demonstrated on an image. And when you give a radioiodine to such patients, excellent ablation will be achieved. And you will also calculate the dose correctly. I am expecting a major change in the scenario of thyroid cancer, especially tennis syndrome, in the years to come with this new concept of converting a dedifferentiated cell into a differentiated cell. So that is all about the differentiated thyroid cancer. Now moving on to medullary thyroid cancer. It was first characterized by Hazard and Associates in 1959. Neural crest-derived parafollicular C cells is the origin of this cancer. Calcitonin and CEA concentrations are directly related to the C cell mass and hence classic markers. 1 to 2% of all thyroid malignancies is the medullary CA thyroid, lower than previous estimates due to rise in number of papillary thyroid cancers. That is, histology has improved significantly, associated with mutations in RET proto-oncogene. 50% of the sporadic cases have RET mutation, and all MEN2A, 2B, and familial MTC have RET mutation. So mutation is an important concept as far as medullary thyroid cancer is concerned. In the MEN1, we have the pituitary adenoma, parathyroid hyperplasia, and the pancreatic tumors. In the MEN2A, parathyroid hyperplasia, medullary thyroid cancer, and pheochromocytoma, and MEN2B has a host of things associated with it. So medullary thyroid cancer is a culmination of many of the diseases together. The middle-aged adults are the common group. Female population is around 1.3. Unilateral involvement of the gland is quite common. Cervical node metastasis is present at presentation. 5% of all thyroid malignancies is MTC. Sporadic form is the most common, and rest in the setting of MEN2A or 2B or familial without MEN syndrome. In MEN2A, MTC 100%, pheo is 40, and para is about 35%. It is a surgery is the recommended before 6 years of age in MEN2A patients. In MEN2B, where MTC is 100%, pheo is 50, and ganglioneuromas are 100%, surgery is recommended in infancy, which is a very, very difficult scenario, but this is a definite recommendation which is existing even today. In my own experience, in 2 patients, when I was at the RMC, we tried, but the family could never accept that ghastly surgical approach at that young infant level. Familial medullary, what is the workup guidelines? Apart from the physical examination, all patients with FNA consistent with MTC should undergo a good physical exam, neck ultrasound, calcitonin, CEA, RET genetic testing. Systemic imaging indicated when calcitonin above 500 or patient has extensive neck disease. Now, I would like to impress upon this because I get a repeated request for FDG, PET, CT and all when the calcitonin is 30, 40, 50. Even at 100, 150, I think one should not get into that. Octrio scan, which is a somatostatin receptor scan, is becoming an important tool, but is not recommended right now. FDG PET scan stands the main study for these medullary thyroid cancer workup. In an FNAC, one of the important things that we should know when you get the FNAC report, atypia of undetermined significance, large atypical cells in a lymphoid background. Here, there is no definite answer given, so excisional biopsy becomes mandatory. And you will have to demonstrate calcitonin stain on the histology to make the diagnosis of MTC. So this is critical. So FNAC, when you get a report, be cautious and try and look back again for furthermore way of getting the diagnosis if the clinical suspicion is high. The patients may present with varied pattern of symptoms. Last week, I was referred by a physician, a patient having 6 months diarrhea and having taken all sorts of drugs, the diarrhea would not stop. And nobody had looked at his neck where there was a nodule in the thyroid. So when I was sent this patient for a FDG PET scan to find out what is happening. When I was seeing, my registrar told me there's a nodule in the thyroid. I said the diagnosis is made. This is MTC with prolonged diarrhea. So patients with diarrhea going on for a long time, neuroendocrine tumors are one of the important things we all should keep in mind. Basal and pentagastrin stimulated serum calcitonin levels are critical. More than 300 picogram per ml is a diagnostic. Serum calcium level to be done, 24-hour urinary catecholamine should be done, or VMA, CEA should be done, and fine needle aspiration, genetic testing. These are at the diagnostic level. In the tumor markers, I already mentioned calcitonin and carcinoembryonic antigen and red oncogene molecular markers. Prophylactic thyroidectomy for affected kindred is a recommendation still persisting in this subgroup. Chromogranin A and NSC should be done in those patients where these other markers are in the borderline scenario. However, calcitonin when high, it does point to the medullary thyroid cancer. At the imaging level, ultrasound and MRI, the octreotide scanning in limited role, but I would say today FDG PET scan is the first one if you need to do a systemic evaluation of an MTC in a pre-op setting. Total thyroidectomy is the treatment guideline. No neck disease, level 6 neck dissection. Level 2-5 neck dissection may be considered based on the calcitonin level. Neck disease present, level 6 neck dissection, ipsilateral neck dissection level 2 to 5, contralateral neck dissection level 2 to 5 if calcitonin is above 200. Adjuvant radiotherapy should be considered in patients with residual disease, extrathyroidal extension, or extensive lymph node metastasis. Less aggressive surgery to preserve speech and swallow may be preferred in extensive metastatic disease patients. Now, this is a very dicey area. One has to balance or trade off. Microscopically, tumors can have different appearances including patterns that mimic other types of thyroid tumors. The most common pattern is a solid growth or nest similar to insular carcinoma. Amyloid, which is present in approximately 80% of the cases, is a characteristic feature of MTC. So calcitonin on one side and amyloid on the other side. Calcitonin stains are usually positive and specific for MTC, but up to 20% of cases may not stain calcitonin and look for amyloid. Therefore, other neuroendocrine markers such as chromogranin, non-specific amyloid, all these should be considered in this scenario. What is the prognosis in MTC? In the early stage, it's almost 100%, 10-year survival. Stage 2 falls down to 93, and stage 4 is just about 21%. 70% patients who present with palpable thyroid nodule have cervical metastasis, and 10% have distant metastasis. A very important statement, and it has a bearing on the workup also. Presenting with T1, 14% central neck disease, 11% lateral neck disease. Presenting with T4, 86% central neck disease, 93% lateral neck disease. Stage and age of diagnosis were found to be prognostic on multivariate analysis. Post-operative calcitonin doubling time is independent predictor of the survival. That means calcitonin estimation is extremely critical in follow-up of medullary thyroid cancer patients. Post-operative management, surveillance, serial calcitonin and CEA, 2 weeks post-op, then 3 months for 1 year, then biannually. If calcitonin rises, metastatic workup, surgical excision of those which can be surgically tackled, and if metastasis, external beam radiation, if surgery is not feasible or other modalities of therapy are not to be considered for any reason. Post-treatment options are, as I said, repeat surgery if possible, external radiation, and now, in the recent few years, an excellent targeted chemotherapy has come up. And there is also a thought process of using isotope-labeled therapies, which is still not proven, it is still in the offing. Now, here is a patient, you see extensive metastatic disease, which you have all in the bone and in the liver, and this is a patient who has extensive disease in the neck and in the mediastinum, and here is the rib and the liver metastasis. Now, these patients today, if you look at, this is a patient on a ultrasound got a neck node recurrence. Conventional modalities like bone scans are performed. Nothing is seen here. And then you perform a lutetium gallium DOTA scan, which picks up metastasis in the bone like this and in the mediastinal nodal metastasis. Now, based upon this finding, this is a somatostatin receptor scan. Medullary thyroid cancer is a neuroendocrine tumor. All the neuroendocrine tumors have somatostatin receptor expression. Based upon that concept, somatostatin receptor scan is being brought into the workup of MTC, but not recommended as of now. Based upon the uptake here, which is present, there is a thought process of giving these patients isotope-labeled somatostatin therapy. This is just for your knowledge, but there is no strong data. We are still waiting. I have done 3 patients, but the response rate was not at all what we expected. This is a patient which I recently done just last month, where you see there is a significant disease in the neck, large nodal metastasis, and the DOTA scan showed uptake in all these areas and also in the mediastinal nodal metastasis, which are present on the CT here. What you see, this yellow color, is the concentration of the radioisotope somatostatin here. Now, depending upon the intensity of the concentration, there is a possibility that the tumor cell may respond. Higher is the concentration of this isotope in these metastatic site, like this here, the response rate is going to come. But we'll have to wait and watch this particular scenario. The last to come is vandatinib. Vandatinib is currently the approved targeted therapy in medullary thyroid cancer. It has done unbelievably major impact in the last few years of the data that have been presented. A phase 3 double-blind trial randomized to 331 patients with unresectable locally advanced or metastatic MTC to vandatinib 300 milligram versus placebo 100 patients. Participants randomized to vandatinib showed a statistically significant improvement in progression-free survival when compared to those randomized to placebo. Now, that is a major important contribution. This difference reflects a 65% reduction in risk for disease progression. Median progression-free survival was 19.3 months in the placebo compared to 30.5 months in the vandatinib group. And because of this, this treatment today has to be considered in all metastatic medullary thyroid cancer patients. The drug is expensive. However, it is available in India today for this group of patients. Now, here is one data picture I am showing. Extensive disease, bone, mediastinum, liver, and after vandatinib therapy, you can see at the end of 4 months, remarkable regression of all the metastatic disease with residual disease in the mediastinum and the neck. So that means we have a modality now, even in the advanced metastatic MTC, to prolong the survival of the patients. The toxicities of these drugs are significant, but one has to carefully manage them with dose escalation or dose minimizing depending upon patients' toxicities. So this data which came of the vandatinib or cabozantinib, both are available now and both have shown significant impact in prolonging the progression-free survival of medullary with advanced disease. Surveillance, how do we surveillance? Doubling time of calcitonin and CEA, very critical every 6 months. As the doubling time decreases, the disease progression will be rapid. So this is a very important point to remember, the estimation of CEA and calcitonin. I want to conclude this talk on a humor. There is a great endocrinologist at Boston who made an interesting study. I can't believe this, but it has been published. In 34 patients of thyroid cancer, he took the dog Frankie, which had been trained, and this dog smelt the thyroid cancer with a sensitivity of 86% and specificity of 89%. Unbelievable scenario. And Frankie today is called thyroid cancer sniffer dog. Imagine all of us going with a dog to our clinic. And here is the last line. This cat had a thyroid cancer, metastatic disease, was given radioiodine therapy, and look, after radioiodine therapy, how great he has become. So this is beautiful to demonstrate even these lovely animals, the role of isotopes as far as thyroid cancer is concerned. Thank you very much on that note.
muted, sir.
Am I audible?
Yeah, you're audible. Dr. Pradhan was speaking. He's muted.
Oh, he's muted.
Okay. The talk is excellent, and all that the students have asked, instead of asking, they're just writing comments. This is a great talk.
Thank
We
you
want
very
to
much.
hear this talk. So I'm going to record it and send it over to all the students.
Thank
But
you.
really beautifully delivered.
Thank you very much.
So well organized. Your thoughts are so well organized. Pratimesh, get some questions from the students.
Yes, sir. So there are a couple of questions that had come in early in the talk as well. And I'll just read out some of them. One of the questions was, can thyroid scan detect ectopic thyroid tissue in the case where thyroid gland is also present in normal location?
Yes, that's what I showed there. In two of my patients where the thyroid was present, thyroglossal cyst was picked up. And in another patient, there was a lingual thyroid. This happened just a few months ago, where we showed both uptake. Usually, by the concept of competitive inhibition, it should not happen. But I did see these two cases. They may be a little unusual, but normally it should not happen.
Right. So there is always a lot of concern that the patients get a thyroid scan randomly. So any thoughts on how to address this? Because the first time people see a thyroid goiter, they immediately send for a thyroid scan. So what are your comments on that?
As far as the thyroid scan is concerned, I don't think it should be used in all patients. In multinodular goiter, there is no role for thyroid scan because it will show cold and hot areas which make no major impact on the management at all. So multinodular goiter is not an indication. The only indication in multinodular goiter is a toxic multinodular goiter where the surgeon would like to do a subtotal thyroidectomy. But there, the subtotal thyroidectomy must include the toxic nodules. If you operate only the non-toxic nodule, patient will come back with a recurrence. So if you have a scan prior to subtotal thyroidectomy and you know which are all the hot areas, all of them have to be eliminated at any cost, even if it comes to total thyroidectomy. So in a toxic multinodular goiter, with there could be some role for thyroid scan. Up in the scenario of solitary thyroid nodule, supposing you have done a ultrasound, you have followed up with a FNAC, the diagnosis has come as papillary CA thyroid, there is no role for thyroid scan. It is an unwanted thyroid scan.
Right.
In a scenario of hypothyroidism, patients with hypothyroidism who are already having a high TSH, the thyroid scan doesn't make any sense because the treatment is thyroxine alone. Whether I show agenesis or a small thyroid, it is not impacting. These are some of the areas where I think unnecessary thyroid scans are done. But over the last 4 decades, I have seen a gradual reduction in the graph of unnecessary usage of thyroid scans. And that's a good sign.
Right, sir. I think more people are now being aware and doing thyroid function tests before they head for a thyroid scan. So you talked about that the thyroid replacement should be stopped prior to doing your thyroglobulin and antithyroglobulin. So what exactly is the duration of this period? Because a lot of people talk about 6 weeks, 8 weeks, 3 months. What is your recommendation?
No, that sort of empirical way is not correct. I was doing that when I was at Tata Hospital in the 80s and 90s. Today, TSH estimation after 3 weeks of surgery will be the way you have to look for withdrawal of thyroxine. If 3 weeks after withdrawal of thyroxine, the TSH is 40, you don't need to further wait. Go ahead and do radioiodine scan, because a TSH of 40 microunits is significant enough to drive the radioisotope into the thyrocyte. And I don't believe that now that concept of 6 to 8 weeks has gone off.
So that will also reduce significantly the hypothyroid state of the patient.
That's right. That's right.
So that brings to the next question about the role of recombinant TSH.
Yes.
Now, you did mention it's an expensive drug, and if our patients can withstand 3 weeks of thyroid withdrawal, would it really be used, and what are the indications, in your opinion?
Actually, I would say that first indication in my view is all affording patients would have a recombinant TSH, because that is the best technique. The whole procedure finishes in 1 week. Whereas you go to that withdrawal scenario, the patient is stuck for 4 to 5 weeks. The whole family is stuck in that scenario. But in an RTSH concept, it's only 1 week. So I personally believe that should become the top line. But if you have a scenario like, a cardiac scenario where withdrawal of thyroxine would endanger some coronary event or such scenarios, I would say that RTSH should become upfront method of using this for scan purpose. So any other contraindication, especially a patient with a neurological symptoms or a psychiatric patient, who are all, thyroxine is a major important as far as brain is concerned. So in all those patients, RTSH makes a big major sense. So what I have done recently, just to inform all of you here, I do not believe the American concept. In America, everything is economy driven. So when RTSH came, they said you have to give 2 injections for diagnosis and 2 injections for therapy. So 1.8 lakhs for one radioiodine treatment, whereas my radioiodine treatment costs only 30,000 rupees. So what I worked upon this, and what I have done now is, when you give the first injection, the TSH is rising to 80. So why not give a diagnostic dose at that time? And when you do we do that now here. First today we give one injection. Next day morning, TSH and thyroglobulin is estimated. If it has gone up to 70 or 80, I give the diagnostic dose that evening. And the scanning is done next day evening or day after in the morning. And that will beautifully demonstrate the metastatic site and the remnant tissue. And then I call the patient, I give the radioiodine order, and next week, with the remaining other dose, I finish the therapy. So I have minimized the cost significantly, and I've argued with the company. I think, how long you would like to continue like this? Because why do I need a TS of 150? I don't need that. Their argument is the biological half-life of this exogenously given TSH is only 8 to 10 days. But I said I'm finishing the therapy during that time. And whatever uptake has taken place has taken place during that 8 days. So I don't need another 2 injections. In this scenario, I have succeeded significantly in many of my patients. So I think India has to come out with a good data saying that this sort of a thing will work up in an Asian scenario, and then I think everybody will accept it.
Right. So I think cost benefit ratio has to be looked at.
Yes.
So one of the questions that has come up is diagnostic scan a must in a low risk patient with very low serum thyroglobulin?
No, I already made a statement. Less than 5 nanograms and all features are going towards low risk. I think don't need to do a scan. There will be some small remnant thyroid tissue, but that may get suppressed by the thyroxine. So I believe now there is a definite recommendation coming that all low risk patients with less than 5 radioiodine can be avoided.
So not even a diagnostic scan.
Yes, not even a diagnostic scan.
Right. So we all normally follow up our patients with thioglobulin and anti-thioglobulin. Do you recommend this at every follow-up? And
Yes.
what is your preference, a stimulated or an unstimulated?
Actually, as of now, what I am doing is I am carrying on with the on thyroxine, thyroglobulin, and anti-thyroglobulin antibody. And I go to the previous pre-treatment scan and see did he have any other metastasis or only residual thyroid tissue. If it was only residual thyroid tissue and small one, and that had been shown to be ablated later on, I just follow on thyroxine, thyroglobulin, and anti-thyroglobulin antibody. Right now, I am
unstimulated.
Yes, non-stim, because it is difficult to getting RTSH. So you have to see the clinical scenario context and take a call.
Right.
I think this is a very, very important
And plus, there is an ultrasound of the neck. High resolution ultrasound of the neck is done. That is quite enough for me to say there is no disease.
Very true.
So you're saying something?
Yeah, this is very important because every time, every 6 or 9 months, you start stopping their erythroxytin to get a stimulated thyroglobulin. I think it's just ridiculous. In low risk cases, yes, a good ultrasound and an unstimulated thyroglobulin estimation is good enough. Every time to put them off thyroxine for about 4 or 5 weeks just unsettles their life too much. So I keep telling your other colleague also at Just Know that don't go on stopping their erythroxytin every 6 months just to get a stimulated thyroglobulin.
Prathamesh, what I would say is,
yes, sir,
good risk stratification if you do, yes, this philosophy will work very nice.
Absolutely.
Yes.
I think that has come out very well in the ATA guidelines where yes, they need to do a dynamic risk stratification.
That's right.
And initial do a modified risk stratification and then follow up with a dynamic. So yes, you are very clear what is the risk of the patient, yes, and what is the current scenario that you're dealing with. And then following a few years of follow-up, what is his current status? So biochemical, structural, disease and response to radioiodine all together give you a very good risk stratification. So there is another question which has come up about the metastatic disease. So in a metastatic disease, suppose you say there's a skeletal met. Now there is a concern that there are some people who will follow up, who will do a thyroidectomy and then do a radioiodine scan and then consider radiation. Whereas there is a group, I mean, especially in Tata Hospital, where we follow that the patient first gets radiation therapy to the skeletal neck, followed up with surgery, and then a radioiodine scan. In your experience, what has shown to be a better way ahead?
Whole body radiation you are talking?
No, sir. Localized.
Pardon?
Localized radiation to the skeletal neck.
Oh, of multiple sites?
To the most painful. To the most painful, and maybe the one which is impending to have or yes, fracture at that.
I strongly recommend that, and I go with it.
So you recommend giving radiation first before surgery? Because
patient has to become comfortable to undergo all the therapeutic procedures. So alleviate his pain or the fracture problem with a local radiation.
Right. So that is very clear, and I think that has come out very nicely that you need to look at the metastatic disease and evaluate how it is troubling the patient. If it is something that is impending fracture or it is having a potential to grow in the period of hypothyroid state, you should consider giving radiation upfront.
Right.
And it is not going to affect your radioiodine uptake subsequently.
Yes, radioiodine uptake will be affected from an external radiation therapy for about 4 to 6 weeks. After that, the vascularity reopens.
Right.
So then the radioiodine goes back.
I think that is very amply clear now, sir. Recombinant TSH is good for diagnostic purpose. Would you also use it in the therapeutic like you said you were using? because the company doesn't really recommend it. So what should we advise the patient?
No, even in the therapy setting, the published data is showing that there is a good response because you are achieving a very high TSH level, which is sustaining for 10 days in the cell, and definitely radioiodine uptake would have taken place by that time. So what you wanted the radioiodine to be in the cancer cell has already occurred, and you expect a good ablative scenario. Because I have a lot of patients where thyroglobulin has come down to 60 to 70% using this modality.
So what proportion of your patients will have an adequate rise of PSH with only one dose of recombinant PSH?
Yes. In fact, in the last about a month ago, we analyzed around some 18 patients. All of them showed a value between 65 to 110 after the first injection. Only one patient showed a rapid rise up to 130. And probably I do not know the reason, but over and all, the published literature is around 80. I have found between 65 to 110.
Which is sufficient for your therapeutic scan.
Oh, yes.
So there is a lot of literature that is coming on to low dose radioiodine therapy.
Right.
So how do you give therapeutic radioiodine for patients who cannot be kept in isolation due to some comorbidity or another? That's one of the questions. So is the low dose radioiodine a possibility in those patients?
That's right. As per the atomic energy regulation, when we give a dose of less than 30 millicurie, you need not admit the patient. You can give the dose and evening he goes home, and all radiation protection measures have to be strictly adhered to at home. That is the current recommendation. So if the residual thyroid tissue is small, and I am sure that I am going to get ablated with a very low dose, 30 millicurie can be given and patient can be sent home. My question there has been, though I am doing that, these are the patients where we already look to them as a low risk category. Right. So why get into that also? Why not keep them on observation and later on take when they manifest the disease?
Right.
But I think it's a debatable issue.
Absolutely.
I did a study in Tata when I was there, 30 millicurie, 50 millicurie, and 100 millicurie for a small remnant thyroid tissue. We came out with the data that around 47 millicurie was enough to ablate the tissue.
Right.
And AIMS, Dr. Bal has come out with a good concept of 50 millicurie dose.
Right, right. So that's bearing out with what you had studied.
Yes.
So the basic question is about what is used to calculate the radioiodine dose. So a lot of questions are about the empirical methods and whether you can actually quantify the amount that you can give. So that brings us to the point about gamma camera versus PET. And going ahead, what should we recommend to our patients?
Actually, neither the gamma camera nor the SPECT is going to make a sense. What is important here is the biological half-life of the given radioiodine. So normally in my earlier days, in the 80s, at RMC, what we used to do was, when we give the diagnostic dose, wherever there is a uptake, we would take 2 hours, 24 hours, 48 hours, 72 hours, the uptake pattern. If the tumor tissue is retaining even at 96 hours, you know that if I give a low dose, I'm going to give a high radiation impact on that cell. If the uptake goes down by 48 hours, more than 50%, that means to achieve the needed effect, I will have to give quadruple the dose. That is how we used to quantify. And using the tomographic SPECT scan, I can volume the tumor very nicely. So volume the tumor and see the biological half-life. Taking these into effect, I can come out with a close to the expected dose that is needed to deliver that 30,000 rats, which I want to give to the tumor cell. So that's why I told you this iodine 124 PET is going to change the scenario. You are going to exactly calculate and volume the disease much superior than what we are doing now. But there is one problem that we have in radiation scenario. Howsoever accurately I do all this, I will always have a biological variation that occurs in a human being, depending upon various other factors. So that we cannot. And the last point is radiation sensitivity of the thyroid cancer cell cannot be quantified. There is no way I can measure it.
Right.
That's a big issue.
So you recommend that any of the current technology is good enough to know about the radioiodine uptake and not necessarily have a center which has a SPECT versus a gamma chemical. That doesn't make any difference.
Actually, in Tata, we have Dr. Basu is doing on that uptake probe, which is the oldest probe that we have. You can beautifully quantify and study the biological half-life.
Okay.
Even on gamma cameras you can do, but the scenario is totally different.
Right. There is a question, is it not a good practice to do remnant ablation without a scan prior to ablation?
I know there is a lot of, some people do think about this. My own issue is like that. I don't think I should irradiate a human body without knowing where is the tissue and how much is the tissue. I mean, that would become a little unscientific. Supposing I know the extent and the volume of the tissue, and from that I can gauge what therapy I should give, I think that would be more rational rather than blindly say that this surgeon must have definitely left remnant thyroid tissue. And I don't think that would be correct. Because I had cases where, especially from Dr. Pradhan, there's hardly any tissue left there. And those people don't deserve even a scan. So forget about the therapy.
Right. So finally, there's one question. Would you use iodine 123 for diagnostic scans?
Yes, definitely if it's available in India, that should be the standard of care. No issue at all. But if it's not available, it will come from Calcutta maybe in 2 years.
Right. I think most of the questions have been answered, sir, very well. I would ask Dr. Pradhan if he has any.
I want to ask you, Prathamesh,
yes, sir.
In the setting of MTC, the so-called familial, are you succeeding in convincing the infants to go through surgery?
So we are having a whole bank now of these familial thyroid cancers of MTC. And about 20% of them have undergone a prophylactic thyroidectomy. So, and this is not just children, but also the siblings and group as such. But you're very right. It's very difficult to convince, especially the adults, to undergo surgery when they don't have symptoms or anything. And we really have to do a lot of counseling for them to go through the whole procedure. And most of them coming from out of station makes it even more difficult. But it is heartening to see that more patients are willing to even undergo the cancer, the genetic counseling. It was difficult to get them to reach those clinics as well initially. Dr. Pradhan, sir.
Speechless. Very well done, Krishna. Thank you very much.
Thank you everybody for participating.
Right.
And Prathamesh, it was a lovely questionnaire.
Yes.
Oh, so these are all asked by the
I know,
participants.
but very lovely questionnaires.
Right. So there's just one last question. So I think this is very important for us about the monitoring of the iodine levels and interference prior to radioiodine scan. I think this is a big issue when we are dealing with these patients. So how should we go about counseling, and do we actually need to monitor this?
Actually, in majority of the patients, given good instructions and all, when they follow, we have succeeded. But in some patients, when it becomes difficult, we may have to measure the blood levels, what we were doing, PBI and all that in the olden days, or urinary iodide,
Urine.
to make sure that the body is not loaded with iodine. But that incidence is very less, because I know that today every compound contains iodine, but according to me, the conventional counseling works very well.
Right. So we don't need to get necessarily worked up about the iodine interference.
Yes.
I think we are done, sir.
Thank you very much.
Thanks a lot.
Thank you, Pradhan.
Thank you
Bye.
very much.
Thank you very much, sir.
Thank you.
Thank you. Bye.
The recording has stopped.